2025 season. It's great to be back, and we have a wonderful event to launch the season this year. We are beginning with a named lectureship. This lectureship is named after Anne Gillis, and I think many in the room know Anne. She has been a central part of our electrophysiology group for many years. And as everyone knows, our electrophysiology group is one of the shining stars of cardiac sciences. They have been highly successful over the last 30, 40 years. Anne is a true clinician scientist. Anne was brought to Calgary by the Alberta Heritage Foundation for Medical Research, an organization that did so much for medical research in Alberta. Anne, I understand, was the first clinician scientist to move through all the levels of the AMHSP or AFMR series. She was a scholar, then a senior scholar, and then a scientist. And in that time, she made immeasurable contributions both to clinical care in Calgary as an electrophysiologist and device expert, and as a researcher. Anne was responsible for really developing our pacemaker clinic. She had interest in sudden death, in ICD implantation. She launched the remote pacemaker reading program. She had an interest in leadless pacemakers, and on and on and on. Anne has been a real credit to our division. We lost her a few years ago to retirement, but prior to that, she had been president of the Heart Rhythm Society, a very important international posting. And in that time, obviously met and formed relationships with many people around the world. And I'm hopeful in this lecture series, we will see some of those people come through. I will hand it now over to Anne to talk a little bit about the lectureship and our guest speaker. Thank you very much.
Thank you, Andrew. It really is an honor to have had a lectureship established in my name, and truly a privilege and a joy to have served in the Division of Cardiology, the Department of Cardiac Sciences, the Libin Cardiovascular Institute, and the Faculty of Medicine in different roles throughout my career. As Andrew mentioned, during that journey, I've had the privilege of being involved in some important innovations in cardiovascular care related to the management of patients with implantable devices and establishment of atrial fibrillation clinics. I have to tell you that like fine wines improving with age, in retirement, my golf game at times has improved with age as well. So although I have enjoyed my career in science and medicine immensely, I'm also enjoying now embarking on other endeavors. Throughout my career, I've had the privilege to travel around the world and meet many incredible clinicians and scientists. A number of years ago at Heart Rhythm, had the pleasure of first meeting Emelia Benjamin, and then more recently working with her. She was leading an NHLBI initiative trying to identify research priorities for prevention of atrial fibrillation that led to the publication of an important white paper on that topic. I think we're all familiar with the Framingham Heart Study and the importance of it in terms of identifying modifiable risk factors for prevention of cardiac disease. And while we may think of Dr. William Cannell as the father of Framingham Heart Study, I consider the present day Emelia to be Madam Framingham Heart Study. She is an outstanding clinician scientist who has published many seminal papers and made very important contributions to our field. And on Sunday, as we were driving through the mountains and chit-chatting, she made one comment that she more recently has been focusing on leadership development of junior faculty to fuel ongoing the future of cardiovascular research globally. But she made a comment that one of her proudest moments is when her mentees have eclipsed her. However, I find that impossible to believe that anybody could eclipse Emelia. So she's very proud of working in an urban safety net healthcare, environment. As you see, she's going to talk to us today about equitable prevention of atrial fibrillation. So welcome, Emelia.
So this is truly a humbling and a great honor to give this lecture. Ann Gillis is one of the giants in our field and has mentored countless men and women. And one of the things that we talked about is your mentors don't have to look like you. And it's really important to think about how do we create a more diverse workforce and have lots of people, clinician educators. We talked about that last night, the importance of our clinician educators and our clinician scientists to really have a healthy, vibrant, and innovative academy. And I took the opportunity when hiking with Ann to get all sorts of pearls of wisdom from her about life and science, her career, and retirement. I would say I'm in pre-contemplation about retirement. And one of the things, unlike a golf game, I do not play golf. I always joke that I can't retire because I have no hobbies and I have no talents, but Ann told me I had to start working on that. So once again, she's mentoring even in retirement. These are my research grants, and I also wanted to disclose that I was a co-chair and incredible honor of the atrial fibrillation research working group for the National Heart, Lung, and Blood Institute. We started out with screening. Ann joined us for the secondary prevention, and then ended with social determinants of health. And that was you really have to take an opportunity. Like the project officers, for some reason, didn't show up on the call, and typical rabble rouser that I am, I fomented the revolution, said, okay, we got to add one more webinar. We have to do social determinants. And they said, yeah, that's great, my co-chairs. And then we proposed it to the, NHLBI leadership, and they said, sure, go ahead. So this incredible honor, and you always have to take those opportunities. When you see a door open, like just run through it. The other thing I wanted to mention, particularly because there's so many mentees here on Zoom, is I think we oftentimes think about what our mentors get out of our relation, what our mentees get out as mentees. And I can tell you that you don't get to give Ann Gillis lecture if you don't have exceptionally talented mentees. Many of my mentees brought forward innovative ideas that weren't even on my radar. And have been incredibly productive, some of them far more clever, far more accomplished than I am, and really feel grateful. I also managed to talk a lot of my competition into doing multi-PI grants with me, and that's been quite joyous also. My learning objectives, I want us to focus on practicing primary and secondary prevention of atrial fibrillation. And if you were looking for a talk on ablation, you can leave now. I'm not going to talk about ablation. I'm sorry. Ablation opens the hospital doors, makes the bottom line work, but we cannot cure the atrial fibrillation epidemic with ablation. Only a fraction of people get ablations, and the lifetime risk of AFib, as I'll show, is quite staggering. We've got to come up with other solutions, or we're going to absolutely bankrupt our healthcare systems. And I also want to focus on identifying and linking data on social determinants of health to atrial fibrillation, and then being a clinician scientist, want to end with what are the critical research opportunities, some of which I will talk about are actually being pursued by your faculty. So the background. I think we all know that atrial fibrillation is a common condition, and it turns out one of the things about working at Framingham is it's been around for 75 years. We just celebrated our 75th anniversary, which is sort of staggering. And unlike most studies, it included women from the beginning. And we were able to look at secular trends or trends over time of various conditions, not based on who shows up at the hospital, but based on routine surveillance. So you can appreciate the gray line is, and I'm going to find my pointer there. The gray line is the incidence. The pink line is the prevalence. And whether you are a man or a woman, both are going up over time, dramatically so. And about fourfold over the generations. The increase in atrial fibrillation, we accounted for age. So some of it is aging of the population, which we know people are living longer, but a lot of it is the good work of cardiologists, right? People are living longer with atrial fibrillation and longer after they develop complications of atrial fibrillation because of better secondary prevention. So it's sort of a good news, bad news story, going up in prevalence, but that's probably a good news because it means people aren't dying of the condition. We also, when people probably don't remember this, but back in 2007 and 2008, the economy crashed and they released these challenge grants. So I called up my competition, Alvaro Alonso, who is in the ERIC study, and said, okay, you all have a risk prediction. We have a risk, it's like everybody's going to get their own risk prediction. Let's just pool our data. Let's do a grant and do it right. So we pooled our data. And now, luckily, I knew he was a nice guy. One of my mottos, and I won't use the crass language that I usually use, but I do not collaborate with jerks. I knew he was a nice guy, so it was worth doing a multi-PI grant with him. Don't sign up for 5 years of aggravation. That's a pearl. So I knew he was nice. I knew he was collaborative. I knew we would spend more time talking about science than talking about authorship. That's one of the rules, can't spend all your time talking about authorship. So these are the factors: race, height, weight, smoking, systolic blood pressure, diastolic blood pressure, hypertension, diabetes, history of heart failure, history of MI. And this gives a simple instrument that we can use for clinical trials or that patients can use to predict their risk. You can appreciate that this is optimal risk factors is 6.8% 5-year risk, 7.6 is normal, the average person. And if you dial in some risk factors, particularly being overweight and having a heart failure, your risk of atrial fibrillation goes up dramatically. It also is a factor not just of clinical factors, but genetic factors. And this is data from the Framingham Heart Study. Shown in this panel are individuals at low polygenic risk. So you do a genome-wide association study and you look at the polymorphisms, sum them up, and you figure out who's at low risk. This is the lowest tertile. This is the highest tertile in this panel. And then we also split it by clinical risk. Lowest tertile is the least saturated, highest tertile is the most saturated color. And you can appreciate that individuals at low clinical and low polygenic risk have a 1 in 5 chance of developing atrial fibrillation. Individuals at high clinical and high genetic risk have a lifetime risk of 48%. That's pretty bloody high, right? 1 in 2. So we should be able to focus on those people and think about how do we either prevent it or postpone it. One of the things I always say is, the one thing you can't prevent is death, right? So what we want to do is we want to be healthy, 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 and then have a spectacular, terrible last 6 months of our lives. How do we postpone compression of morbidity? How do we postpone the onset of atrial fibrillation? This is a wonderful collaboration we have with individuals in Denmark. This is an early stage investigator named Nicholas Vintner, and he took the entire data set of Denmark and looked at the lifetime risk of atrial fibrillation between 2010 and 2011 and 2022. And lo and behold, yes, they also observed the lifetime risk of atrial fibrillation was increasing from 24% to 31%. People of European ancestry, lifetime risk about 1/3. That's what you have to remember. So what happens? This is you develop AFib before the age of 55. What are the complications afterwards? And you can look till extinction, basically till 95. Systemic emboli and MI, 2 and 10%. All of the strokes, any stroke is about 20% lifetime risk. You develop atrial fibrillation, your lifetime risk, about 20%. So what's the most common complication after AFib? Well, death, okay? But after death, heart failure. Where is the guideline? Where are the randomized data to prevent heart failure? Research opportunity, right? And given that the lifetime risk is 42%, you're not going to have to wait around for your entire career to have enough events to actually prove a difference. So this is an incredible opportunity. So let's look at the actual data. primary prevention. So you're trying to prevent the emergence of atrial fibrillation. I'm going to show you a lot of meta-analyses. It obviously would be unethical to randomize somebody to, please smoke and be a couch potato versus don't. Okay. So this is all observational data, and that's as good as it's going to basically get. With the exception, I almost threw in the slides and then I was told that I only had 45 minutes. But the one thing that actually can't be biased is Mendelian randomization. And when you look at the Mendelian randomization, most of the risk factors turn out to be very strong in Mendelian randomization studies, so including obesity. So when you look at BMI per 5-unit increment in BMI, the lifetime, you have about a 1.28 or a 28% higher risk of developing atrial fibrillation. We know this, and this is part of what's driving the atrial fibrillation epidemic. We also know very few studies, no studies have really looked at primary prevention of AFib, having AFib be the primary outcome. What they do have is secondary analyses of other studies. So I'm going to show you one particular study, but there's a meta-analysis that proves the same thing. Whereas you look at atrial fibrillation incidence, randomizing people to intensive systolic blood pressure control, less than 120, and standard systolic blood pressure control, less than 140. And you can appreciate the hazard ratio is 0.74 or a 26% reduction. So we need to be doing a better job with blood pressure control. And anecdotally, my father had AFib. I'm on 2 blood pressure medications to get my blood pressure less than 120, also to prevent the dementia that both my parents had. So hopefully one of those, it'll prevent something, hopefully. Okay, SGLT2 inhibitors. Again, these were not studies that were really set up to look at atrial fibrillation as an outcome, but they looked at individuals with diabetes, heart failure, or CKD. They took the randomized data and then post hoc analyzed or looked at the AFib risk. And it looks like SGLT2 inhibitors have a relative risk of 0.82. I anticipate that there's going to be a cottage industry of, GLP-1s and SGLT2 inhibitors coming out for secondary prevention. Probably they're going to work for primary prevention as well. And then what about alcohol? 1 drink per day, this is like, how it's like 1 drink a day keeps the doctor away. Like that is the alcohol industry. That's just completely bogus, bogus science. And so what we know is the more you drink, there's a dose response relationship. So we all grew up, Todd and I and Ann trained in the days when people would come in after a bender and it was called holiday heart. And we knew that we've known that for 4 decades, right? But this thing about the dose response relationship is a newer observation. Very few people and clinicians really focus on that. So what did the ACC-AHA guidelines say? Patients at increased risk of atrial fibrillation should receive comprehensive guideline-directed lifestyle and risk factor management for AF targeting obesity, physical inactivity, unhealthy alcohol consumption, smoking, diabetes, and hypertension. We wanted one for each one of those, and they said, you got to go on a diet, pretend like you all are I was a co-author on this, the ESC, and we got to shorten our document, which of course we didn't succeed, but we did combine them all. And when you look at the ESC guidelines, they're pretty similar. So maintaining optimal blood pressure, they focused a lot on heart failure therapies to prevent AFib, maintaining weight, active lifestyle, and drinking. So all of the same things. What about secondary prevention of atrial fibrillation? One of the, I think, advances of the new AHA-ACC guidelines is we got on board with the heart failure concept of AFib is not a condition that emerges when you show up with your first EKG of AFib. AFib is a life course phenomena, similar to heart failure. So similar to heart failure, stage 1 is people at risk for AFib, and that's the presence of risk factors. Very few physicians ask if you have a family history of atrial fibrillation. It's important. It does markedly, and I don't have time to show the data, but it markedly increases your risk of AFib. Stage 2 are people who are pre-AS, structural heart disease, either electrically or anatomically, predisposing a patient to AFib. Stage 3 are people with paroxysmal, persistent, longstanding, successful AF ablation. And then they may transition to stage 4, which is permanent AFib. What I want to point out is the unifying factor across every single stage is treating modifiable risk factors. And we as a profession are doing a miserable job of that. The ESC guidelines also have a major emphasis on what they call care. And the beginning of care is comorbidity and risk factor management. So again, we align both the Europeans and the US guidelines. I would say that the ACC-AHA actually isn't just US guidelines, because we had people like Prash Sanders. We have people from other countries also in the Heart Rhythm Society, which is not I mean, it's based in the United States, but it's not just a United States organization. So what is the randomized data? We know that weight management versus lifestyle decreases AF symptom burden. This was published in 2013 in JAMA by colleagues Abbott and Prash Sanders group out of Australia. Now, one of the things that's disconcerting as somebody from the United States is we kind of stink at these studies, man. We just don't publish. Most of these studies come from Northern Europe. Some of them come from Canada. And then the other ones come from, most of them come from Australia. So yeah, anyhow, that's a sadness. So on the vertical axis is symptom burden control. And you can appreciate those that had weight management. And we're not talking like losing a couple of pounds. We're taking 10% body weight. That's pretty ambitious, and very few of us can achieve it in our practices. Have lower AFib symptom burden, fewer AF episodes, and the cumulative duration of atrial fibrillation in minutes is much lower, 692 versus a decrease in 692 versus an increase in 419 minutes. So really significant difference. Very hard to replicate. And I think the reason why most of the studies haven't replicated is very few people have achieved that 10% weight loss. Again, stay tuned. We were talking about this yesterday and last night. I think that we're going to be having some of these SGLT2, GLP-1 inhibitor studies coming out saying that actually it can reduce AFib burden to actually lose weight with those more effective medications. That is not, at this point, not yet evidence-based. The 2023 ACC-AHA guidelines said in patients who are overweight and obese, weight loss is recommended with an ideal target of less than 10% weight loss to reduce AF symptoms, burden, recurrence, and progression to persistent AF. So as we're going through the secondary data, look at where we're actually changing AFib as an outcome or changing complications from AFib, because it varies depending upon the actual risk factor. The ESC guidelines also said weight loss is recommended as comprehensive risk factor management for overweight and obese individuals. There is some randomized data on exercise. One of the things, they have a natural experiment in Australia, which you all obviously could implement here because you have 1 to 2 year waiting lists for AF ablation. You can do a lot of these studies. And I know that you're participating in a study with Ratish, okay, I'm going to get the name wrong. Help me out. Thank you. Rasta AF, which is looking at cardiac rehab for atrial fibrillation. Unfortunately, in the United States, cardiac rehab is not a reimbursable diagnosis with AFib as the indication. I've asked multiple people here, and it is an indication here. So you all actually can implement exercise in your patients. You can refer them to cardiac rehab. Exercise led to decreased recurrent AF, improved symptom burden, and AF free at 12 months. The hazard ratio is 0.50. So this is AF free survival at 12 months, 20% in the control, 40% in the exercise. That's pretty impressive. I talked to Eric Protowski. I don't know if people know him, but he is Dr. AF. He's, been very involved with the Heart Rhythm Society, the Stop AFib, the patient organization, et cetera. And he says, he's done intensive lifestyle modification en route to an ablation and had some of his patients say, do I still need my ablation? And it's like, lo and behold, they don't. So we're underutilizing this. ACC-AHA guidelines, again, say in individuals with AF. Now, the ping is not related to exercise, because this is one of those things. Usually there's a linear relationship. This is a J-shaped relationships, and elite athletes do have an increased risk of atrial fibrillation. That has not been a big part of my practice in an urban safety net hospital. I just got to and I suspect that, it does happen. There are, people who have it in relation to exercise. I don't know if you know this, but interestingly enough, this hasn't been documented in women. It has been documented in men, and we don't know. Is that because women don't have as much intense exercise, or is that because there's actually a physiological difference and we don't know? But in people who don't have exercise-induced AFib, moderate to vigorous exercise training does reduce AF symptoms and burden, and also improves quality of life. So that's something we need to think about. ESC guidelines also, tailored exercise program recommended in individuals with paroxysmal or persistent AF to improve cardiorespiratory fitness and reduce AF recurrence. This is an area where we differed a little bit from the ESC guidelines because we doubled down on smoking, and they were sort of, they mentioned it in the paragraphs, but they didn't have a guideline on it. And this is observational data. Again, we don't have randomized data on smoking. It's just never going to exist. Clever study design. They took a national healthcare database, and this is, I know that you all are doing the same thing here where you have the entire province, you have a database that's very, very granular where clinicians, scientists, and clinicians and PhDs can interrogate it to ask important questions. And so you can do this type of study. So they characterized people at their first and second health exam and looked at those who had developed AFib in the interim. And so these are people who never smoked, ex-smoke, quit smoking, and current smoking. And what they observed is when you compare these people who quit smoking, so they, longtime smokers, quit smoking, they had a 17% reduction in their risk of developing dementia and follow-up. So I didn't talk about that, but that's actually one of the complications of atrial fibrillation is dementia. And so again, very important to think about smoking. ACC AHA guidelines, people with a history of smoking cigarettes should be strongly advised to quit smoking, should receive guideline-directed medical therapy for tobacco cessation. So we actually know how to treat smoking. It's not something like, where you just tell people to do it, but they actually can't do it because there aren't tools. And it changes AF complications and other adverse outcomes. This is something every physician should do in a patient with AFib. Alcohol abstinence, this is a randomized controlled trial, again, out of Australia, where they took, it was multi-center, open labeled for obvious reasons, and they recommended abstinence or, just usual care. And the control group, the probability of being AF free at 180 days was only 27%. Those who were abstinent, half of them were AF free, just from abstinence. And even some of those people drank a little bit, but again, they markedly decrease their risk. Hazard ratio is 0.55. So we recommend individuals with AF seeking a rhythm control strategy, minimize or eliminate alcohol consumption to reduce AF recurrence and burden. How many people have friends or colleagues that have atrial fibrillation? Okay. And how many of them tell you anecdotally that they notice if they drink, they get more paroxysms? Right? People put it together. When the doctor is mum on it, they're going to keep doing what they're going to do. So we need to do a better job in health communication to our patients. Reducing alcohol consumption to less than or equal to 3 standard drinks per week, not per day, per week, is recommended as part of comprehensive risk factor management. This is the European guidelines. Blood pressure lowering. This is, again, data that wasn't the primary endpoint of these studies was not atrial fibrillation, but they did participant data meta-analysis, participant-specific data analysis. So they gathered all the randomized data, 188,000 individuals, and then looked at AFib onset after being in the trial. And what you can appreciate is there's a dose-response relationship, that the more you lower your blood pressure, the less your risk of major cardiovascular events. And, huge difference in individuals, whether they had AFib or no AFib. So there's no interaction. So we need to be lowering the blood pressure in individuals with AFib. It's a 91% hazard ratio for 5 millimeter reduction. And I don't know about you, but my blood pressure was over 140. Again, I'm driving it down to less than 120. Okay, for patients with AF and hypertension, optimal blood pressure control is recommended to reduce AF recurrence. So here it's both recurrence and related cardiovascular events. Good data for both. And similar ESC guidelines, blood pressure lowering recommended to reduce the recurrence and progression of AF and prevent adverse cardiovascular events. As somebody who was on the guidelines, it's always very reassuring because people love to talk about how the guidelines can't agree on anything and, blah, blah, blah. There actually was most of the things actually agreed, which means that, people, groups of data, when you're on these guidelines, I'm sure many of the people in this room have been on them. I mean, it is a boatload of work because the first thing you have to do is you literally have to download every single study on the topic and go through it to make sure that you're not just going with your little anecdotal impression, but you're actually basing it on the evidence. And for both the ESC and the ACC-AHA, you can go online and look at the trials that they downloaded. Because we have to have that disclosure because there's been an enormous amount of cynicism about guidelines because of people having conflicts of interest. Now, a little pearl is if you don't do any industry collaborations and you're in the AFib space, you get on more nice study statements, guidelines, et cetera, because there's so few arrhythmia experts that don't have conflicts of interest. So that's been one of my strategies, not to mention the fact that I'm lazy and I hate filling out conflict of interest forms. So that's the other problem. So how are we doing? This is data from Hess. It's older, but there's more recent data that shows the same thing, where they looked at people who had atrial fibrillation and 90% of them had an indication for some evidence-based treatment. Lo and behold, what percentage of people actually received all of the evidence-based treatment by other guidelines? And it was less than half. Even if you aren't looking at the AFib guidelines, if you look at all the other guidelines, people are getting undertreated. And I know this is an area of great concern and some of the reason why you all in your health system are trying to think about how do you have more remote clinic, remote opportunities? And speaking with Todd Anderson, how do you actually have a training program and medical students go out to the community so you have more physicians in the community that can practice these guidelines? So the ACC-AHA recommends comprehensive care addressing guideline-directed lifestyle and risk factor management for all of the reasons we've talked about. And we talked about clinical care pathways. This was a 2A, meaning probably a good idea, but not as solid. And this was based on some randomized data. And the ESC guidelines also gave it a 2A. Patient-centered AF management should have a multidisciplinary approach. I don't think that the 2A means it doesn't work. I think the 2A means that these studies are really, really hard to do. For instance, I talked to Michiel Rienstra, who did one of these studies. Part of the problem is there's so much crossover and contamination between who gets what. Let's do the thought experiment. How many of you spend in an average encounter, half of the encounter talking about lifestyle and risk factor management? Okay, nobody's raising their hand, right? That's why we need multidisciplinary teams. The ESC guidelines also came out. This is a little bit different than our guidelines. They recommended SGLT2 inhibitors for people with heart failure and AFib, regardless of the EF. We didn't really focus on that because we have heart failure guidelines to do that. The effective glycemic control is recommended as part of comprehensive risk factor management. And this was interesting. I talked to Anne about this because this was the one thing that really stood out to me because we had a lot of discussion about whether we should include diabetes or not. They gave it a class 1, but C means consensus. And when you actually look at the data is not brilliant, for glucose control. I think that's probably because most of the studies are older studies. And, we know that there are a lot of different ways to get control of lipids. And not all of them are as effective in terms of outcomes. I think the same thing's going to be true about SGLT2 inhibitors and many of the other glycemic control measures. So what do the 2024 guidelines say? They kind of summarized all of this with the CARE, which is comorbidity and risk factor management. But they also emphasized equality and healthcare provision. And we had done that also in our guidelines, and I'll show that data to you. So that is a good segue to systemic barriers for atrial fibrillation. So this is one of my favorite slides. And the reason why I like it is I want you to notice that the organization that's promulgating this is the American Hospital Association. Now, this is 2018, and I think, I don't know anybody who knows American politics, but I think we can safely say the American Hospital Association is not a hotbed of progressive politics, okay? This is like, no, and even they said, only 20% of outcomes is due to things like healthcare. But all of our healthcare dollars are spent on this 20%. Instead, health behaviors, 30%. So maybe we do need to be spending half of our time in our encounters with patients talking about health behaviors, because it's probably evidence-based that it's actually going to make a difference, okay? 10% is physical environment, 40% is socioeconomic factors. And this has been looked at a lot of different ways, some of them much more complicated slides. I think this is an important message that we need to walk away with, is we spend, I don't know if there are any medical students here, but we spend 95% of our time, at least I did, in medical school talking about healthcare and very little time talking about this. And this is what we need to be turning our focus to if we want to make a difference in population health. So I'm going to cover only a few social determinants. I'm going to start with education and income. Very, very clever study out of Molisani, Italy. And they took people with low life course disadvantage versus high life course disadvantage. And they looked at the cumulative risk of AF admission. And the reason why I love this slide is, I don't know if there are any family practitioners here or any people who do pediatrics, et cetera, or take care of younger adults. This is a life course phenomena. You know, you start developing the milieu for atrial fibrillation probably before you're 5 in terms of weight patterns, et cetera. So they took people who had low life course disadvantage, both in childhood and adulthood, and people who had very high life course disadvantage in childhood and adulthood. And what they observed is those that had both high in childhood, high in adulthood, had a 57% increased adjusted risk of atrial fibrillation hospitalization. But the wonderful news is education. So you started out with, you know, high life course disadvantage. Education mollified that or mitigated that. And there was a 50% decrease in the cumulative risk of AF admission. This is a study from, I can't remember who I talked to about Abdel Kader, and I sent the reference. This is an important study from Ontario, and the kind of study that you all can now do, that you have a database for all of Alberta. You can start geocoding and mapping your atrial fibrillation incidence, progression, outcomes, treatments, et cetera, to the neighborhoods with geocoding. Anyhow, he looked at individuals with the most versus the least socioeconomic material deprivation in their neighborhood. So he didn't take what the individual's deprivation was, he took what their neighborhood was. And you can appreciate those that were in the most deprived neighborhoods were less likely to receive anticoagulation, less likely to receive cardioversion, less likely to receive ablation. Look at that, 0.45. And I want to point out, this isn't a system that has universal healthcare. This isn't the states. This isn't, you know, the lower 50 states, right? This is a mess. You all can actually do this because you can pay for it. And then what are the outcomes? Well, this variation in treatments was associated with increased mortality, increased stroke, increased bleeding, and increased heart failure. Very important data, and data that I think you all can be doing here in Alberta and Calgary. What about geography and rurality? No, I got to show this slide. Okay, do you know what this is? This is the farm where I grew up. I've never had anybody guess that I grew up on a farm. Outside Eugene, Oregon, that's the barn where we took care of sheep and I played. Okay, so rurality. Sorry about that. Okay, rurality. This looked at in-hospital mortality. It's national inpatient sample data. And you can get access to all of these data sets, by the way. Most of the data that I'm showing you can access and analyze yourself to test your own hypotheses. Rural is shown in orange, urban is shown in blue, and in-hospital mortality is the axis. And you can appreciate they looked at 250 admissions with AFib. Rural individuals were more likely to die overall, and all of the subgroups, whether you're a man, woman, race, region, higher likelihood of dying. So why would this be? You know, there are disadvantages with being in an urban, very, very urban, higher environmental pollution, inequities in income, transportation, and food. But the rural areas, and this may vary a little bit in Alberta, but I suspect not much, higher risk factor burden, higher rates of, well, maybe this isn't true for you all, the uninsurance or underinsurance, big issue is transportation barriers. People having to drive 4 hours to get to the electrophysiologist, low volume healthcare facilities, and limited access to healthcare. I'm now going to turn to race and ethnicity. And here we're looking at individuals that are Black versus white. And these are people who did not know that they had atrial fibrillation, and they had a routine ECG as part of this REGARD study and had their atrial fibrillation detected. And what they observed was people of African ancestry were less likely to be aware that they had atrial fibrillation, and they were less likely to be treated. So that's very disconcerting. This is a study out of Pittsburgh Medical Center, single center, but I wanted to show you one slide rather than 10 slides because it captures a lot of different things that we care about. And what you can appreciate is individuals who are Black relative to individuals who are white had a 90% increased risk of stroke, an 86% increased risk of heart failure hospitalization, a 39% increased risk of mortality, and a 50% risk of getting an ablation. They were 50% less likely of getting an ablation. And Pittsburgh is one of the top 10 medical centers in the United States. So this isn't like some backwater hospital system. This is pretty stark inequities. And what I'm not saying, this is not about skin pigmentation. This is about social determinants of health. This isn't about race per se, because we know that's a social construct. This is about structural racism and also interpersonal racism. And some of that shows up in our clinical trials, okay? So this was done as recently as 2020, and they looked at clinical trials. 44% of the clinical trials didn't even bother to report race. That's a problem. You know, it's like, no, I can't see you. It doesn't work that way. You gotta come clean and report what your race data is. A little anecdote here. I asked people what percentage of the population here were indigenous. And it was fascinating to me. That should be a pretty straightforward number that everybody should know. And I think I asked 4 different people throughout the course of the day what it was. And I got 1%, 2%, 4%. And your dean told me it's actually 6.5%. That's not a trivial number. That's not a trivial percent. And it's interesting, both the knowledge gap of what percentage of your population in all of Alberta is of Indigenous, and also, an important opportunity to really make a difference. And I think, I know that you all have now in community health sciences just hired 2 Indigenous investigators. I think it's going to be very important to look at your AFib data by Indigenous status and very publishable. And hopefully you won't just observe it, but you'll figure out how to make a difference, because that's what's really important. Okay, so racial minority population, these are the clinical trial participation, the most saturated. And I'm going to show the middle bar is the US Census. So 86% white, 85.6% white, 10.3% Asian, overrepresented relative to their representation in the population. Look at Hispanics, 18%, 5.6%, so a third. That's structural racism. 13% versus 2% for African American, that's structural racism. One of the things, Martha Hill, I don't know if you knew her, she was a president of the American Heart Association, the first nurse president, many years ago, like, decades ago. One of the things she said to me when I think I was like a junior attending, like my first or second year, she said, we have to remember African Americans are not hard to reach. They're hardly reached. That puts the locus of control on us. So that's very important reframe of what we're looking at here. So the ACC guidelines, regardless of sex, gender, race, ethnicity, adverse social determinants of health, should be equitably offered guideline-directed stroke risk reduction therapies, rate rhythm control as indicated, and lifestyle and risk factor management to improve quality of life and prevent adverse outcomes. And the ESC guidelines gave it a 1C, similar concept. We need to start treating everybody equitably. So, you can say, well, that's what people in the C-suite, the dean, the people who, manage Alberta Health, et cetera, they can figure that out. But what can we do as clinicians? The first thing we can do is diversify our training programs. I think you have 4 out of 13 fellows are women. Now, I don't know what it's like it here, but we've been 50% women in medical schools, you know, we've been 50% women in medical schools since 2000. So it's not a pipeline problem, right? That's a culture problem. And when you look at cardiology versus surgery, surgery is 40% women. They don't have an easier lifestyle than we do. So we can't tell ourselves a story, well, it's just, you know, a hard lifestyle. So we need to diversify our training, and it's even, you know, probably more stark when it comes to Indigenous people and different races, ethnicities, et cetera. And part of it is it makes it easier to deliver quality care that people trust. It also means that we're going to have an easier time recruiting individuals to our randomized controlled trials, and we're going to do better science and better clinical care. We need to advocate for policy changes and support research to establish evidence-based implementation. What I said to a couple of people is, if I had to do it over again, I wouldn't be an epidemiologist. We've got to stop observing stuff. We got to figure out what to do about it. I want to be an implementation scientist in my next life. Are you practicing primary and secondary prevention? If you don't have the time to do this, do you have a multidisciplinary team or an AF center or a nurse? I know that that's part of what you're going to be trying to do in your clinic. So what are the research priorities? So that brings me to Rupi Sandhu, Dr. Rupi Sandhu, which is, you know, one of the things that she's going to be doing. I didn't show the data on sex and gender because I'm sure she's going to be giving a talk about this, but they're profound inequities by sex and gender. And, you know, for a lot of different reasons. It shows up in inequities in treatment, inequities in outcomes, and et cetera. So a lot of research opportunities. And Dr. Sandhu has really introduced very important multifactorial, you know, research, education, clinical agenda to really make a difference in terms of women's health outcomes in cardiovascular disease. So hats off to you, and I'm looking forward to seeing your data. And, you know, how are we doing in the United States? I just put this in so you all could feel really smug and good that, you know, here, you know, since over time, this is thousands in healthcare. This is in the 80s. The gap isn't so bad about the life expectancy or the amount of money we spend. In 2021, United States spent almost twice as much money and had about, you know, had a gap in mortality of about, you know, 8 years. I mean, it's so depressing. Anyhow, so what is CMS doing about this? CMS is our main funder of older adults, 65 and older, Center for Medicare. And they now have it in their quality program that it's going to be mandatory to screen for social drivers of health and figure out, it's not enough to screen for something. You got to figure out what you're going to do with it and develop a plan to do something about it. And the only way you ever motivate change, at least in the American system, is to make people, you know, to pay people for it, right? So it's going to be a payment determination. So I think people are finally, the healthcare administrators are going to pay attention to this. And the Joint Commission also is saying, got to have it as, the Joint Commission is our health, the organization that goes around and accredits hospitals, have to designate equity champions, assess social needs, stratify key quality. You got to not just observe it, then you got to implement a change plan. So this is an important quality improvement and also an important research agenda. So to summarize, because I promised Dr. Sandhu that I would end a little early and we started a little late. So here we go. What do I want you to walk away with? Very good data now for primary prevention to decrease the risk of atrial fibrillation. So individuals, class 1 recommendation, lifestyle and risk factor management. For secondary prevention, very good data, some of it randomized. Randomized, so level of evidence R means randomized, obesity, exercise, alcohol limitations, or abstinence. Not randomized, smoking cessation, hypertension treatment. Comprehensive care for lifestyle and risk factor management, level of evidence A. And future research priorities, we need to develop more pragmatic studies to examine prevention strategies for diverse AF outcomes. So not just stroke. We don't need another DOAC, okay? We need to figure out how we actually, and I talked to, I think Dr. Sandhu, if I'm not mistaken, about how, you know, even in Canada, where you've got 100% health insurance, there's marked inequities in terms of people who's getting anticoagulation. I showed some of that data earlier. Okay, and we want to talk about how, and this was part of the NHLBI workshop on social determinants, about these inequities are amplified across the life course of AFib in risk factors, in diagnosis and trust, symptom control, shared decision-making, and downstream outcomes. And so what do we think the research priorities are? We have to increase the diversity of our recruitment and retention strategies for patients in observational pragmatic studies by race, income, and education. Most randomized controlled trials now do collect sex and race, ethnicity, probably education. Most of them don't do income, and also most of them, I didn't talk about this, don't talk about health literacy, and that's another important social determinant. We need to increase the settings. And so I know one of the things you all are doing is citing, Dr. Sandu is citing her primary care, her women's clinic at another hospital that's a little bit farther away and not at the mothership. We need to develop innovative methods to analyze multiple intersectional identities. People don't just have they're not just a woman, or they're not just Black, or, whatever. People have multiple identities, and we don't really know how to analyze them, the complexity of how things are across different identities, and also the cumulative disadvantage over the life course. And then finally, we need pragmatic studies to test multi-level strategies to mitigate social determinants of health in AFib diagnosis, management, and outcomes. And I hope that if I could give this talk in another 5 to 10 years, we'll actually have more of an evidence base about what do we do about it, and not just describe it. And I wanted to thank you all for your attention. And by the way, this is a slide that I made on Ann Gillis. Look at all these awards, peer review, editorial boards, publications, third woman president of Heart Rhythm Society. And the last line is mentor's mentor. Thank you very much for this honor.
Before it open to questions. Yeah. Open the room to questions, and people online, if you will open the chat window, if they want to put questions there. Ruby.
Emelia, that was a wonderful lecture. Thank you so much for coming. I wanted to ask you just about a practical approach and focusing on secondary prevention of AFib. So you have patients come in and they have multiple risk factors, and their lifestyles are usually poor. And it's overwhelming for them to hear everything that has to be done. So is there an approach you have to prioritizing modifiable risk factors or giving lifestyle advice, and does that vary by sex?
Wow. So that's
I want to repeat the question.
Yeah. So the question is, patients are overwhelmed. You've got, like I just outlined, multiple risk factors that we want them to think about. And most people don't just have one risk factor. That's fairly unusual. They tend to have multiple risk factors. And how do we actually address that so they can make achievable gains? And does that vary by sex? Okay. So vary by sex, we know that women are less likely to attend cardiac rehab and less likely to persist in cardiac rehab. So I have to imagine that that plays out, and you would know the data much better than I do across multiple risk factors. Women, however, are more likely to show up to a lot of other appointments. So, it's very complicated. What I would say is you have to meet patients where they are and figure out what are they motivated to change. If they say, look, I'm not changing my drinking, I wouldn't spend a lot of time on it. You have to figure out what is, it's how do we do behavior change? I mean, this is like the medical students probably know this better than we do. You have to assess what is their motivation, what's a relevant risk factor. The guy in the car driving me to the hotel when I first got here, smoked, and he wanted to know about smoking. And was it bad for him? Mind you, he was of South Asian extraction and had all of his male relatives that had heart attacks between 45 and 50. So I was like, yeah, probably not a good idea for you to smoke. Okay, so and then we kind of talked about, well, why do you want to, why would you want to quit smoking? Do you want to get to your daughter's graduation? Do you want to get to your daughter? Here I am trying to, anyhow, I'm hopeless, right? I said, by the way, it does cause erectile dysfunction also. I threw that in as well. Okay, so I actually didn't use that word. I said sexual dysfunction. He probably wouldn't know it. Okay, so bottom line is you got to meet with people where they are. But the reality is most physicians do a miserable job of this because it takes time. And most physicians, I don't know if this is true, but in the United States, you're booked for 20 minutes with a patient for a follow-up. You can't do behavior change. How do you do a discussion about anticoagulation, shared decision-making in 20 minutes? I mean, you got to talk about that, right? So it's not realistic. This is where we have to have multidisciplinary clinics. We only gave it a 2A recommendation because the randomized data isn't that good. And that's why I think it's very important that you all are participating in the cardiac rehab. Here you can get it, if you don't have enough time, which I suspect you don't have enough time, send them to cardiac rehab. Apparently, few people do that. I mean, that'd be a really interesting study. Just look at how many people get referred to cardiac rehab with AFib. It can get reimbursed, do it. We need to do better. That randomized trial is going to be very important. In the United States, we can't get it reimbursed unless they have another comorbidity. Did I answer your question? Thank you.
Rob?
Yeah. Yeah, yeah. Yeah. Yeah, so that's a really important observation. And frankly, that's a whole other talk. AFib predisposes to heart failure predisposes to AFib. We just published MIs predisposed to AFib predisposed to MI. Most relationships with AFib are bidirectional. It's very interesting. And, because they're conditions of aging. One of my favorite Shattuck, I don't know if the New England Journal has a Shattuck lecture, and Braunwald, that guy is so bloody brilliant. He published in 1999, facing 2000, saying the twin epidemics of the next millennium is going to be AFib and heart failure. The thing that makes me really disappointed is people don't focus. If you've got AFib, how are you going to prevent their heart failure? You better well treat their hypertension. If they have high heart failure, how are you going to prevent their AFib? We published this, actually, Tommy Wang and I published this years ago, that, maybe 10% of the people show up on the same day and you don't know which came first. And sitting at review for 3 decades, you don't know which came first. But a lot of times one precedes the other. It's very common. It goes both ways. The problem is we don't have a brilliant evidence base about how to prevent the next, the comorbidity after the sentinel event. And that's what we really need to focus on. And I feel like stroke is important. The lifetime risk is lower. The relative risk is lower. Okay. Everything about it is lower, and the attributable risk, the absolute number. And we don't have an agenda for heart failure. That's an important research opportunity. And by the way, there are enough events. You don't have to wait for, you can actually do some of this within a randomized control trial.
If we can check the chats.
Oh, there's one.
There you go.
Oh, thank you very much for asking that question. So the question is, do environmental factors affect AFib prevalence, e.g. tropical versus no tropical? I don't know tropical versus no tropical. That's fascinating. There's a very, very rich literature about environmental pollution, increasing the risk of atrial fibrillation, both onset. They've done studies where they look at devices, so triggering and an increased risk of incidence of AFib, an increased risk of paroxysms of AFib. So environmental pollution definitely affects the risk of atrial fibrillation and probably the risk of complications.
I have a question for you.
Perfect.
So you talked about minority groups not being enrolled in trials and laid it down to us having to engage those groups.
Right.
Do you have any kind of thing to say about disenfranchisement and lack of trust in these communities with health research?
Yeah. So if people haven't read the book Medical Apartheid and they care about this topic, it is a must read. I tell everybody who works at my hospital, they've got to read it, because we do a lot of victim blaming. We blame, African Americans are ignorant and they have the lack of trust in the healthcare system. Well, no, there is a historical legacy that literally goes back 400 years of the experimentation and exploitation of people of African ancestry. I mean, you read this book and you feel ill. Like you try to read a chapter, you have to force yourself to read it. But there's such a legacy, and I don't know about the legacy of experimentation on Indigenous people, but I know a lot of the data around education. And, I think that the same thing has happened probably with Indigenous people, maybe not the experimentation, but the disenfranchisement and the abuse of Indigenous people. So I don't think we can say that the trust is misplaced. There is a historical legacy of why people mistrust the healthcare system that we have to own. We can't blame people. Now, how do we make a difference? I think, this is why I would be an implementation scientist, is we've got to do community engaged research. We've got to engage the communities. We've got to involve them in the design of the research and the research questions and the implementation of the strategies. And this is why we have to have a more diverse workforce. We have really doubled down. Many of our research assistants and people that are recruiting are people of African ancestry and Hispanic and are fluent in Spanish. Now that's our demographics. So this is something we can make a difference. We can't just say, well, they're hard to reach.
I think it gets back to the point you made of the time allocated to spend with the patient. You can't build that trust relationship in an interaction, correct? It gets built over time.
Yeah. So Anne basically Dr. Gillis just raised the astute point. Trust takes time. It takes focus. Just a little thing. I think there was a study that just came out of Medscape that if you stand during a hospital and patient interaction versus you sit, changes the trust. How much time does it take to sit down, for gosh sakes? If you're looking at the computer versus talking to the patient, so we have to own some of this. I don't want to blame my colleagues because, I also do burnout, vitality, stuff like that. I'm not saying that they're bad, selfish, dumb doctors. People are under stress. We've got to change the system so that people can spend more time. That's one of the reasons why we need to have more PAs. I know you just started a PA school and more nurse practitioners because they have more time. They're less expensive and probably they can do it better. So we have to have more teams. This is surgical management of AFib. So you're probably referring to the Maze procedure, and you can go to the guidelines to look at the level of evidence in the class recommendation. It does have a role for atrial fibrillation. If somebody's getting surgery for another indication, sometimes doing a Maze makes sense. So I'll leave it at that.
If there are no more questions in the room, well, thank you very much for visiting Calgary, and we really enjoyed it.
Okay.
That was fun.
Yeah.
How do you like my last slide?